Every minute, someone's life takes a terrifying detour, not down a dark alley, but into the sterile, bright halls of healing. They walk in seeking care and find themselves plunged into a nightmare. Most malpractice claims in hospitals are related to surgical errors, whereas most claims for outpatient care, which accounts for more than half of the paid malpractice claims, are related to missed or late diagnosis. Now, before you raise a pitchfork at every white coat you see, let's be clear. This isn't an indictment, it's a revelation. Because the truth is, any provider, any nurse, any human being capable of brilliance is also capable of a mistake. This is about understanding why and using that knowledge to build a safer future for every patient who walks through those doors. Scrubs and Subpoenas, Tales from the Witness Stand, a podcast where we'll peel back the sterile sheets and delve into the real stories of medical malpractice. Each episode, a cautionary tale, a blueprint for change, a reminder that even in the darkest corners of human error, there's a light. The light of knowledge, the light of empathy, the light of a future where healthcare becomes not a gamble, but a guarantee. So join us as we dissect the mistakes, illuminate the flaws, and ultimately learn to heal not just bodies, but the very system itself.
Get ready to listen, learn, and earn CE hours. This podcast features content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits.
Hello and welcome to another episode of Scrubs and Subpoenas, Tales from the Witness Stand. I'm your host, Jana Emil, and joining me again is Dr. Sally Miller. Dr. Miller, thank you for joining me again for another story.
Always a pleasure.
Awesome. We're so happy to have you. Dr. Miller serves not only as faculty here with FHA, but also as an expert witness, right? I said expert witness, like you are the only expert witness for medical malpractice cases, specifically NP cases, right? So this is really interesting. Dr. Miller, we get on these, we talk about these stories, these real cases that you've worked on, really from the perspective of learning and understanding. I think the big thing that we want everybody to always understand listening to these podcasts is that mistakes can happen to any single one of us. And in fact, mistakes will probably happen to every single one of us, especially those of us that work in healthcare. And that kind of is the nature of the beast, right? And this is an opportunity for us to listen to, real cases, real things that have happened when things don't go quite as perfect. And how do we learn from that? How do we take, these cases, these opportunities to practice better, right? And to maybe practice, at a level that we feel really confident that we're making great decisions, and that we're not falling into some of the common pitfalls that, let's face it, just happens. And I think about myself as an RN and the things that you get really used to doing that maybe you're like, oh, I'm a little too relaxed in that way. And it just helps to reset, personally myself, it really does help me to kind of reset my mind frame and think about these things a little bit differently. So super excited to hear the story, Dr. Miller. This is always a really good opportunity to learn. I always learn new things and to think a little bit differently. So I'm going to be quiet now, and I'm ready to listen to what you got for us.
I was gonna add something to what you just said, but I think I'm gonna wait until after the case, and then see if it be. I know it'll be like a cliffhanger,
Yeah,
everybody can be on to their seat checking it out. So yeah, I do have even yet a different kind of point to make about this one, but maybe you'll get there before I even have to highlight it. So this is a case of a 24-year-old female. So she's younger than both of us. We've talked today, on different episodes about cases of somebody your age and somebody my age. This one, I guess, is probably young enough to be my granddaughter if we really stretch it. So I can't identify there, but she's 24-year-old female. And so she presented herself for admission to an inpatient detoxification program. So this was a 24-year-old female who had an opioid use disorder. She was addicted to heroin. And again, these cases, by the time I can present them to you, they've been through the system. They have either been settled or gone to court. And so it's always several years out before we can even talk about them, because from the time something happens, there's 2 years of the statute of limitations to even file the complaint. And then the attorneys get involved, and then they amass the witnesses and the documentation and all of that. And that can take several years. And then they get court dates, which invariably are put off. In fact, I have 3 court dates scheduled for the end of this year that were originally scheduled for the middle of 2023. And they
Oh my
just
gosh.
get postponed because somebody can't make it. And so, I mean, I just say this to let you know that the cases I generally can talk with you about often are 10 years old, because these are the
wow.
ones that are actually settled, or, you know, they've settled or been adjudicated or whatever. So this case is just around 10 years old. And so this 24-year-old patient presented herself with her, and it was heroin. What made me think of all of that was fentanyl wasn't even a big thing yet. Like
Oh
10
my
years ago,
gosh.
fentanyl was what we used to manage your cancer pain when you had hit a dose ceiling with morphine, you know, because fentanyl is so much more
Wow.
potent. So anyway, she had a heroin addiction, and she had a 4 to 6 bag a day heroin addiction, which is, you know, sort of middle of the road. And she'd been using it for a couple of years. Before that, she had been on Percocet for some extended period. So she is a well-established patient with heroin addiction. She also admitted to smoking cigarettes, which was probably the least of her problems, but she had a 10
Yeah.
cigarette a day habit, marijuana, alprazolam, aka Xanax. I always laugh when people call it alprazolam instead of Xanax, thinking it doesn't sound as bad. Like we
Yes.
don't all know what alprazolam is.
Xanax
And
got a bad connotation, I think.
I know, somehow it sounds. In fact, I always when someone calls it alprazolam, I have to stop myself from thinking, "Uh-oh, I'm being manipulated here." um, and nitrous oxide, just to round out, you know, the abuse here. So that was
Nitrous
what she was.
oxide? Is that what you
Yeah,
said?
yeah, yeah,
Wow.
yeah.
Okay.
Oh, from what I understand, it can be fun. I don't know.
Oh
It can
my
also, you
goodness.
know, be very dangerous, but that's beside the point.
Yeah.
So anyway, she had, you know, she had a history of using all of these, but she is presenting herself for inpatient detoxification and to begin treatment of her disorder. The primary drug of abuse that was her concern at this point was the heroin. So she went, you know, they go through the emergency room at this program. The program is articulated with the hospital. You know, it's physically located in the hospital, a different
Okay.
managerial structure and stuff, but it's in the hospital building, and you have to go through the ER. So that's what she did. And she was in withdrawal when she was there. The admission notes that she was having classic withdrawal symptoms like, you know, the hot and cold flashes, a lot of cramping, body aches. There's agitation for sure, but a lot of GI symptoms with heroin withdrawal. Because when you withdraw from heroin, you're withdrawing you're withdrawing this cholinergic system. So basically their cholinergic system goes into high overgear, which is why the GI thing accelerates: nausea, vomiting, diarrhea, even sometimes urinary incontinence, all that kind of stuff. There is also, of course, an agitation response, and she was having all of it. So anyway, she's there. The nursing documentation notes it. This is a good time to get her into care now that she's begun withdrawal. So she's admitted, and she was admitted with, you know, standard orders, a standard protocol for opioid withdrawal protocol. She also was admitted with an order to continue her outpatient medications. She had psychiatric diagnoses, and she was on some psychiatric medications as an outpatient, which is not at all unusual. You know, I think the vast majority of people with a use disorder, it started because they were self-medicating symptoms, or because they were prescribed something, and then an underlying personality disorder or something just facilitated a dependency. So anyways, I know, without
Yeah.
going off on too much of a tangent, there's almost always an underlying psychiatric disorder with a use disorder, whether it's diagnosed or not. In her case, it was diagnosed. She was on some meds. So let's see, what are some of the stats here? She was admitted, and the night she was admitted, she started to evidence withdrawal. The next day, you know, she was admitted on methadone. At the time, that was primarily the thing that was used in the
Yeah.
inpatient setting. She was admitted on like 10 milligrams of methadone, and then escalating. And then there was just a protocol, you know, the skeletal muscle relaxants like Robaxin, and the like Anaspaz for the GI motility, and clonidine, just to calm down the sympathetic nervous system from the brain down. Like there was a whole protocol there, and she was put on it. And the protocol included compazine for vomiting. And so the next morning she was throwing up, and she got compazine, and it didn't help. Um, Later that morning, the day after her admission, when the nurse came in to evaluate the patient, she said she had been vomiting all morning and the compazine didn't work. So the nurse called the APN on call, and the APN on call gave a verbal order for Zofran, ondansetron, 4 milligrams, orally
Mhm.
disintegrating tablet, right? So you might guess from the way I highlighted that that becomes a bone of contention later on. So she was ordered the Zofran, and the Zofran was administered. Like an hour later, the APN came to the bedside. She evaluated the patient. The patient, still was having some nausea. I guess her vomiting had calmed down a bit, but she was still symptomatic. She was having very classic withdrawal symptoms, things like, the agitation, the GI motility, some
Yeah.
diarrhea. Typical stuff. The APN documented a physical examination. It was consistent with a patient who was in a controlled opioid withdrawal. At this point, she did have clonidine on board. She had methadone on board. Now she had the Zofran on board. So her symptoms were starting to calm down, but they're still, it's certainly not a perfect physical exam. So it was documented appropriate with what you would expect.
Right.
According to the nursing notes, and again, this isn't a hospital per se. Like, yes, it's in the hospital building, but it's not a hospital unit. It's a detoxification unit, and their protocols are a little bit different. Their supervision is not quite as robust. So the patient will have periods of the day, excuse me, where she's not being directly supervised. But during the day, apparently it was uneventful. In the afternoon, the nurse documented a complaint of headache and body aches, again, both very consistent with opioid withdrawal. The evening nursing assessment recorded a complaint of nausea, also consistent with opioid withdrawal. The last dose of Zofran was given at 5 o'clock that night. So again, this is like not 24 hours since her admission, right? She came in the evening. She had a little withdrawal overnight. She got started on her protocol. In the morning, the compazine didn't work. She got Zofran. The day was essentially uneventful. She had a headache. She had some body aches. That night, she was still nauseous. She got another dose of Zofran at 5 o'clock in the evening. The evening hours of that day and the early morning hours are documented as uneventful with no complaints recorded. The next morning, the morning of so we have the evening, the full day, 2 doses of Zofran. The next morning, let's see, at 7:39 a.m., nursing documented an ADL assessment that was, within normal limits as expected, nothing significant. About an hour later at 8:35 in the morning, the day shift nurse entered the room to perform her assessment and found the patient unresponsive with agonal
Oh.
respirations.
Oh my God.
A code was called. Code protocol was initiated. The patient was resuscitated, but experienced anoxic encephalopathy. And she was stabilized, meaning she didn't die, but she was, permanently, she was, permanently unresponsive. She was anoxic. She had anoxic encephalopathy. She was stabilized. She was 24, strong heart. She was resuscitated, and she was ultimately, she went to she stabilized, and then, in the hospital for a while, and then she went to a rehab facility, and then she was transferred to home, but she was still transferred to home needing full care because of her encephalopathy. And that was
Oh
the
my
last I heard at the time of this case. So it's a pretty short discussion of events here. But
Wow.
so what do you think the bone of contention? I told you the APN's role was she was called early in the morning to respond to the nausea and vomiting. The patient
Right.
did not respond to the compazine, so the APN gave a verbal order for Zofran, 4 milligrams. Then she came in about an hour later and did her assessment. That was unremarkable. And that was it. That was the APN's interaction here. And so, of course, the APN was the subject of the complaint that I was involved in. So what do you think could possibly have been the
I mean,
assertion of deviation?
well, the one thing I'm stuck on is Zofran. um, and 2 things. 1, because you highlighted it. 2,
Mhm.
because I feel like I remember some just like in my own like nursing brain, something about Zofran. It's like one of those things that's like the weird things that happened. But wait a minute. Wait a minute. So the unremarkable bit too, if this patient was, I'm curious about, there's nothing remarkable to document if this patient was actively going through withdrawals and was very, very, very sick. I mean, sick to the point that was vomiting, that med wasn't working, so now Zofran had to be ordered. Like, something's missing here.
Well, I mean, in withdrawal, you are uncomfortable for sure. And
Right.
the documentation was like, it was consistent with the withdrawal. It wasn't like she had a totally
Oh, okay.
normal
So not like
exam. It was
nothing at all, but
consistent.
saying
Yeah.
she's behaving
And
like you
also,
expect. Okay.
at this point, she had received methadone, she had received clonidine, Robaxin, like, the whole protocol of
Yeah.
withdrawal meds. So she was medicated at this point too. So she wasn't perfect. And I thought I mentioned that, and maybe I didn't highlight it clearly enough. But during the APN visit, the exam was consistent. It wasn't a normal exam, but it was consistent with her opioid withdrawal.
So what's the encephalopathy is throwing me, Dr. Miller. Like at first I'm like, it honestly, like, was she just like too much meds and like bottomed out, like respiratory wise, or but the encephalopathy is throwing me.
Well, so the encephalopathy was documented as anoxic encephalopathy. So
Okay.
she went, for whatever reason, she went too long without air. She
Yeah. So
was
like
without oxygen.
respiratory depression, is that something that was
Mhm.
happening?
Well, that's the $30 million question. I mean, on that end, again, there's lots of different pieces to this. Lots of people
Yeah.
being sued for, did they not do stuff right? But, and then of course at 7:39 in the morning, the patient was documented as being, responsive, normal ADL, stuff like that. And then at 8:35, which is what,
Just
56
not.
minutes later, she was
Yeah.
unresponsive. So, what happened in that interim? Did she aspirate? Did she aspirate and then choke or did she vomit? And so nobody knows how she got to this place, but 56 minutes later, she was unresponsive and her respirations were agonal. So who knows how long her respirations were not productive. But to bring the NP into this suit, the only thing the NP did was prescribe Zofran and then document a visit that was consistent with her withdrawal. And so, what the assertion was, dragging the APRN into this. I mean, I'm not saying something might not have gone wrong, but the
Yeah.
only thing that this APRN did was prescribe Zofran.
So
And so,
Zofran wrong? Like what's happening?
bad I love Zofran. the, the assertion was, and the listener can decide how valid this is. Like, number one, nobody seems to know why she became unresponsive. Did
Yeah.
she aspirate? Did she cardiac arrest? Did she go into a dysrhythmia? Nobody knows because she wasn't even monitored. This wasn't a hospital bed. This wasn't an ICU.
Ugh,
She was, so
right.
we don't know. We don't know. But the assertion was by the plaintiff that she was on a medicine that prolonged the QT interval and that she probably had like a run of VTAC and died. And that it was because the NP put her on Zofran that could prolong the QT interval
That's the thing I had
in
in my
combination with
brain.
methadone. So the assertion was that the NP should have done an EKG before prescribing the Zofran because of the methadone.
Oh, wow. I don't even
So,
know about it's like
well, I mean, I knew a little bit going into this, but definitely
yeah.
before the case had to do some research. But so methadone is notorious for prolonging the QT interval in high doses.
Okay.
There's a lot of debate actually in the literature. Like that's one of the things about methadone, one of the safety issues is that in high doses, it can prolong the QT interval. That's really not debatable, but the high doses is the key phrase. So in the world of methadone, the literature is clear that in doses over 100 milligrams a day, there is the potential for a prolonged QT interval. So anybody
Okay.
who's on 100 milligrams of methadone a day, that's definitely a consideration. So under that amount, so when we look at methadone dosing, excuse me, generally the evidence-based literature will tell you to try to stay under 20 milligrams a day of methadone. In
Okay.
real life, anybody who manages opioid use withdrawal will sort of laugh at that, haha, because that's like not much better than waving methadone over somebody's head.
Wow.
We very often use higher doses than that. When we look at the dose conversion, like the morphine milligram equivalents, anything under 40 milligrams is considered a low dose of methadone. Like, and I shouldn't say acceptable, no particular safety concerns. this patient had just been titrated. She's only there for a day. She got there on the night of, we'll say day 1. All day, day 2, she got her Zofran. In the morning of day 3, this happened. So she was on a methadone titration protocol, and it started off at like 10 milligrams twice a day. So based on the way the order is written and the sign-outs are documented, there's some bone of contention about how much she actually got, but the absolute most was 50 milligrams for the duration of that, really, her stay there, which was not much more than 20 hours. So on 50 milligrams. So of course, then one side is going, well, it's over 40. So there's an increased risk of a prolonged QT interval. So the nurse practitioner should have done an EKG. And then of course, the other side says, wait a minute, it's nowhere near 100 milligrams. The literature is really ambiguous on this. Like there's that whole debate of not doing a bunch of unnecessary tests on people.
Right.
She was 24 years old. She had no cardiac history that was documented, that nobody knew of. She was 24 and she was being titrated up on methadone. At the time the NP gave the order, it may not even have been that high. So should the NP have ordered the ECG? That was the whole thing here. Should the NP have ordered an ECG before giving the order for Zofran? So the plaintiff's report, the plaintiff had 3 experts to testify against the nurse practitioner. So I guess I'm giving it away here. I was not one of them. I was retained by the defense.
Yeah.
The plaintiff had 3 experts, 2 physicians and 1 nurse practitioner. One of the physicians was a cardiologist with a particular expertise in QT interval prolongation. Like that was his life's study.
That's so specific, huh?
He was recruited because his expertise was QT interval prolongation.
Okay.
And in support of his, of course, look, somebody who spends their whole life studying the QT interval,
yeah,
of course they think, like that's just, like everybody in psychiatry thinks you have a mental health disorder. Everybody in orthopedics thinks you have osteoarthritis. I mean, we tend to see things through our own world. So a cardiologist with a particular subspecialty in QT interval prolongation is really not equipped to speak on the standard of care of a nurse practitioner.
No.
And I mean that was one of my biggest bones of contention. He's seeing it through his own lens. He also, to support his position, he cited a single reference that was that supported doing a 12 lead for everyone that was on Zofran.
One
but of course,
reference.
Yeah, and there are tons of others that are really much more nebulous. It really is under 100 milligrams a day, like the combo of methadone and Zofran. If the patient was on more than 100 milligrams a day of methadone, yes, then there would be enough concern about QT prolongation that it would have been harder to defend,
Yeah.
But this person just really should not have been opining on the care of this nurse practitioner, and that was part of my defense of her, was that her care is not being evaluated by somebody in a same or similar, clinical expertise and experience.
Right.
And then the other physician was a cardiologist, perhaps not a QT interval specialist, but the other physician was a cardiologist, and the nurse practitioner was a nurse practitioner who had only ever practiced in cardiology. And really, her opinion really echoed that of the cardiologist. And cardiology, of course, their bias is that everyone should have a 12-lead ECG. Listen, if you ask a gastroenterologist, they would have said she should have had an endoscopy.
Right. Right.
Right. I mean, there's just GI scopes everybody. Cardiology, they EKG and echo everybody because it's what they do. And I really don't mean that tongue in cheek. I mean, that's the way they see the world, because by the time patients come to them, there is usually a reason to do that.
Mm-hmm.
They're not in that same place as a generalist or a primary care provider who is seeing a 24-year-old woman with no cardiac history. And as it turns out, she had an ECG in an emergency room record from like a year prior, and there was no QT prolongation. Like the whole assertion here was, what if she already had a prolonged QT interval, and then methadone made it worse, and then we gave her Zofran? And it's just really a ridiculous assertion at this point.
Wow.
but that was the, and so the thing, you remember we said in the beginning of this case, I said, and there's another thing I wanted to mention, but I
Yeah.
think I'll wait till the end.
Yeah.
So, I mean, sometimes we make mistakes for sure, whether it's a mistake in care or documentation or whatever. But like in this case, there was no mistake. She didn't do anything. I don't think she did anything wrong. I don't think anybody listening here would have said that
Mm-mm.
before ordering that Zofran, she should have done a 12-lead ECG. How many of
Mm-mm.
us have prescribed Zofran? And even if it's not methadone, there are plenty of meds out there that are asserted to prolong the QT interval. In fact, people that use electronic prescription writers, I know you can identify with me when I say every time you try to order something, you get like 4 red exclamation points that say, red alert, don't do this and that together. Try to order Motrin. Oh, here, I mean, literally with Motrin, you will get alerts about not using them in obesity.
Wow.
Well, I mean, like, it's just the script writers are that aggressive about alerts, and it doesn't take long at all before you don't even see them anymore, honestly. I mean, maybe it's just me. I hope it's just me. I hope
Oh,
everybody
yeah.
else, but I mean, you tune them out after a while.
It's
So
true.
it really comes down to your clinical judgment and your understanding. And so listen, hopefully anybody who's listening, if you have a different opinion, you please email us. I'm happy to hear it. But
Mhm.
I genuinely don't think that a nurse practitioner in the same or similar circumstances would have said, oh, before I order 4 milligrams of Zofran, which we give to a 5-year-old,
Yeah.
before ordering 4 milligrams of Zofran, I better get an ECG on this 24-year-old patient with no cardiac history who is taking a dose of methadone that is appreciably under the threshold for concern about QT prolongation.
Yeah, this
So
sounds like one of those, like, very obscure like, very obscure things that, like, you'll write a story about because, like,
because it'll never
if
happen
that
again.
was the actual case, right?
It is the plaintiff's attorney's job to to advocate for their client. And they're just going to look through this and try to find whatever they can. I mean, I don't want to sound disrespectful to plaintiffs' attorneys because
No.
they serve a purpose too. And there are patients who are on the receiving end of a true deviation of standard of care, and they need those attorneys to help them, to
Yeah.
help them recover in any way, to be made whole. I totally support that. And there are circumstances where I will testify in a plaintiff's case when the NP really did deviate from a standard of care. If for no other reason than because I want all of us to be practicing within the standard of care because we still are struggling with some of the biases about nurse practitioners. It's gotten a lot better,
Yeah.
but we are observed under a closer lens. And so I don't want any of us to be out there practicing in deviation of standard of care. So yeah, I have no problem holding an NP accountable, but in this case, I don't see it. I just can't imagine.
Yeah, and with so many of these cases, I mean, I tend to agree with you because we acknowledge this when we talk about these cases that it's really easy to find like the things that, oh, here it is. This is where the first
Mhm.
thing went wrong and the second thing went wrong. This for me listening was not one of those that was a very like, oh well, here's where we find the issue there. And I'm wondering, I just don't know enough about this topic, but I'm wondering, Dr. Miller, did they ever, could you, I guess really is my question, on this patient do an ECG post, this event that happened unfortunately to her to show, like, would it still show if she had QT prolongation and that
Mm.
in fact was the cause? Like, can you go afterwards to check for that, or that's not really how that works?
No, at this stage of the game, she
Yeah.
had so much downtime that
Yeah.
that alone would have had a significant impact on her 12 lead. So you really couldn't get a sense of what it would have looked like before. I mean, there were all sorts of theories asserted here about why she went unresponsive in the first place. And the one really that I tend to favor, and it's not a bias, it's just statistically speaking, it's not all that unusual for people um in these kind of detox facility that somebody will come to visit and bring them something.
Mm.
I mean,
Oh my
I don't know if I
gosh.
should say not
Didn't
un
think
it
about
happens.
that.
It totally happens. It totally
Yeah.
happens. And if she overdosed,
Yeah.
because methadone in combination with some other opioid could totally do that. And I don't know at all if that's what happened. Nobody knows. Nobody knows what
Right.
happened, but this was just one assertion.
Wow. So what happened to the NP in this case, who's like, from my perspective, seems to have just a very, very, very small like role in this story?
Yeah, no, nothing. I mean, there was a settlement from the facility because there almost always
Okay.
is going to be when a young person has such a catastrophic loss like
Yeah,
that. But no, the NP. The other thing, of course, of interest is that it's not the first time Zofran was ordered there. Like it's a place where people vomit, and if there were any sort of concern, they would have surely had a protocol for doing EKGs at the time of admission.
that's
You know,
true.
so.
That's true. Do those guidelines exist like today in these types of settings? As far as like, are there actual guidelines that are kind of loud in your face that say, if this, you know, for instance, taking methadone and over this amount, do an ECG before you give that? Like, is that a set in stone guideline?
No, that would be, I mean, we have literature that is very clear that if your methadone is over 100 milligrams a day,
Yeah.
there is a significant risk for QT prolongation.
Yeah.
But how that translates, it really would be up to the facilities. Facilities have
Okay.
their own protocols. And, I mean, it's just the nature of the litigious 21st century that
Mm,
unfortunately many protocols are derived based
mm,
on things like this happening. So
yeah.
undoubtedly, the other thing that there's been a real big shift to buprenorphine products,
Oh,
for
yes.
withdrawal rather than methadone. I mean, methadone is
Methadone.
still used out there. There's a role for it, and there are patients for whom it is the better option. But there's been a large switch to buprenorphine, which also can prolong the QT interval. I mean, buprenorphine is not it's not like the be all end all perfect drug. It's got issues too, but comparatively from that perspective, it's much safer.
Wow. Wow. This was an unexpected turn, and this was really hard to try to figure out what happened. And still, honestly, it sounds like we may never know actually what happened.
No, it's funny. Like sometimes you just want to say to the person taking your deposition, "Are you nuts? Do you really
Yeah.
believe this foolishness?" And in this case, the attorney that took my deposition was also a physician.
Oh,
And
wow.
like they have their techniques about how they will come at you. Well, why couldn't she have done the ECG? Why shouldn't she do the ECG? Or why shouldn't she have done it? And it's really not why shouldn't she do it. The question is why should you do it? Like for any
Right.
diagnostic test, the question is why should you do it? And in this circumstance, there was no reason to do one. But they're just like word games that get played. And for a skilled interviewer, a skilled attorney, it really can make the difference to a jury. Like you can see the jury
Oh,
going, "Well, why shouldn't she do it? It's only like what? How much does it cost? $20?" But yes, but if you multiply that by doing like a million of them unnecessarily every year,
right.
it all comes back to our healthcare premiums. I mean, like that's the idea. We should only be doing diagnostic testing when it's indicated, when there's a reason to do it. And
Right.
I remember just being like, my response to that question was so incredulous. It was just such a silly question. And in a clinical circumstance, she would have known it. But in her job, trying to, make a case for her client, that was part of how she tried to go about demonstrating that there was a deviation. And all I could say was, that's not the question. The question isn't why wouldn't you do it? The question is why would you? And here
Would
there is
you?
no answer to that. Yeah.
Wow. We like to really end these with like the big takeaways for NPs. And often I can think like, oh, well, this is a good thing to think to tell an NP. This is a good thing to think. This one, I can't. I mean, honestly,
I
Dr.
mean,
Miller.
I can give you a takeaway for this. A takeaway for this one is that when MPs are subject to a suit, like when they are the subject of a malpractice action, it's scary and intimidating, especially if it's the first time.
Yeah.
I've read so many depositions of nurse practitioners, like this one, who is the subject of the case, and they get unsure and frazzled and let these very skilled plaintiffs attorneys talk them into things that they really don't mean to say. Like
Oof.
why wouldn't you do that EKG? Well, I don't know. There's really no reason I couldn't. Like that's not, that's what
Yeah.
somebody might say if they're unsure, they've never been deposed before, they're scared and all that kind of stuff. So the takeaway from here is for sure, if you are confident in your care, or even if you're not, if you're being deposed, be firm either way. But when
Yeah.
you know that you have done nothing wrong and you haven't done anything wrong, be firm in that, and don't let anybody intimidate you into saying something you didn't mean. Don't let them push you into answering a question. There's all these little techniques where you feel rushed, you feel like you have to answer it. You might try to give an answer even if you don't really understand. There are certain phrases that attorneys will use, like, is this an authoritative reference? In some states, authoritative reference is actually defined by law to mean certain things, but you don't know
Oh,
it.
wow.
Like, so just don't let yourself be intimidated into answering a question you don't understand or saying something you don't mean. Don't be intimidated into agreeing with a statement when they say, well, would you agree that X, Y, and Z? Well, why not? Well, would you agree that A, B, C? And I'll read these depositions and see people like, I think, no, you didn't mean that. Don't say that. That's not what you were supposed to say. But they do it because they're scared and intimidated and unsure.
Wow. That's frightening. I mean, let's
Mm-hmm.
be honest. That's frightening. It's frightening to get in trouble in
Mm-hmm.
any degree,
Yes, it
good
is.
and for this, my God.
We always overthink
Wow.
this stuff. Oh no, my license, like,
Mhm. Mhm.
but don't think that way. Don't think that way. And don't if somebody and if the person taking your deposition needs to intimidate or try to force an answer from you that way, it's usually because they don't have a very strong case,
Oh yeah.
you
That's
know?
a good point. Frightening
So
stuff.
that's the
Wow.
takeaway from that one.
Wow. Good. This was a really good story. This was an kind of an eye opener, I have to say, for me, in the sense of like when you really don't see
Yeah.
anything coming, and how some things can just come out of, I don't want to say nothing, but come out of the dark that you didn't even
Mhm.
expect. Oh my gosh.
Mhm. And
Wow. Thank you,
it's the
Dr.
nature
Miller,
of
for
the
that.
beast.
Yeah,
It's the nature.
it
It's
is.
like, oh, like, oh, what about this one article? Should I have ordered that? No. And the answer is no. Don't doubt yourself. If you're confident in what you did, well then,
Yeah.
you answer the
Yeah.
question about what you did. Take your time to answer the question. If you don't understand it, have them repeat it. If you can't answer it, just say, I can't answer that. That's the
That's
takeaway.
good advice. That's good advice. Dr. Miller, I appreciate you as always. This was a great story. Thank you for this.
Always a pleasure.
Awesome. And we hope you guys enjoyed this and learned something new. Definitely things that you can apply, right? Take it with you. Practice strong, practice confident, advocate well. We really want you to do awesome things. And if you're looking for more stuff to listen to or just resources from us, check us out on fhea.com. See what else we got going on. We hope you enjoyed our podcast, and goodbye for now.
This podcast featured content from an accredited CE activity provided by Calibri Healthcare. Visit elitelearning.com/podcasts for accreditation and disclosure statements and instructions on how you may be able to earn CE credits. Take your learning to the next level by subscribing to more podcasts on compelling healthcare topics.